Dear Chairman and dear my friends in India, and I want to thank the organizing committee for inviting me to join the AIOS 2021, and I have no financial interest to disclose. Today I'm going to talk about, is this an isochoria pathologic or pharmacologic? As you can see that this is a diagnostic flow chart modified from Dr. Alexandridis, and he has been separated into 3 parts. And the first one will be the larger and reactive pupil, and which will be focused on using some pilocarpine test. And the second part will be the smaller unreactive pupil that will be we should consider about chronic AD's pupil. And for the third part will be the pupils who shows normal response. And in this category, we would think about the simple anisocoria and also the Horner syndrome. And today we are going to focus on the larger and reactive pupil. Let's look at the first case. That would be a 20-year-old male patient, and he had headache and nausea, vomiting for 1 year, and which is relieved after rest. It occurs with increasing frequency recently, and he denied diplopia. He was referred from the neurosurgeon for the evaluation of an isochoria. And as you can see that his vision was good, and his EOM was full, except for a minimal limitation of A deduction in the left eye. However, he have a fully dilated pupil in the left side, and which does not respond to 0.1% of pilocarpine after 40 minutes. And then we use 2% of pilocarpine test. It constricts partially to 6.5 millimeters. And the MRI show a 2.1 centimeter soft tissue lesion over the left paracellular region. And the differential diagnosis include arachnoid cyst or cystic neurogenic tumor. Surgical intervention has been suggested, but the family decided to observe. And he has been followed up for 5 years, and his anisocoria and the paracellular lesion remain stable. So cerebral palsy may present as an isolated mydriasis in arachnoid cyst. Dr. Herster has reported isolated unilateral mydriasis with delayed onset oculomotor palsy secondary to a arachnoid cyst. And Dr. Ashker also reported an 8-month-old boy present with an isochoria and with cholinergic supersensitivity as the only sign. Ductal deficit and ptosis were absent. 19 months later, he had developed an concomitant axal deviation with supraduction deficit. Brain MRI revealed the arachnoid cyst compressing the third cranial nerve in the right interpeduncular cisterna. So 1% pilocarpine may also exist in dorsal midbrain syndrome and also cerebral palsy. It is presumed that transsynaptic neuronal cell death may be the underlying pathogenesis for the cholinergic supersensitivity in the cerebral palsy. So in this case, we learned that cerebral palsy may also present as an isolated anisocoria without the clinical manifestation of EOM limitation or ptosis. Cholinergic supersensitivity exists not only in AD's pupil, may also occur in cerebral palsy, dorsal midbrain syndrome, Miller fissure, and migraine. Let's look at the second case. The second case is a 38-year-old female patient, and she complained about blurred vision, especially for the near target with photophobia, and she visited municipal hospital in June 2016. The vision was good, however, her left pupil was dilated. She admitted that she had helped her son to take eye drops for myopia control. And her fundus and OCT scan was normal. In August, she returned to the municipal hospital again and said that the dilated left pupil resolved spontaneously 1 month later. The same condition occurred in the right eye. She was absolutely sure that she did not touch the myopia control eye drop for her son recently. As you can see, her intraocular movement was full, and she was referred to our hospital with CD copy of MRI. She visited our clinic on September 26th, and the vision was good, and you can see that right pupil was mid-dilated to 4.5 millimeters. And the dilated pupil does not respond to 0.1% pillow cupping after 40 minutes. Then we use 1% of pillow cupping. It constricts partially to 3.0 millimeters. And her MRI showed there is a lesion over the interpeduncular region at midbrain level on T1 weighted image. Differential diagnosis include lipoma or dermoid cyst. And we look into this MRI in more detail. The upper row is the T1 weighted image, and the middle row is the 3D Viesta, and the lower row is the time of flight. And on your left-hand side, that would be the upper level of the midbrain. You can see the optic chiasm over this region. And at the middle row, that would be the middle part, and you can see the pituitary stalk. On your right-hand side, that would be the lower level of the midbrain, and then you can see the carotid siphon over here. And the lipoma is located over the upper and the middle level of the midbrain, which is hyper-intense on T1 weighted image and the heterogeneous intensity on the 3D Viesta. On this middle level, you can see the lipoma is associated with a linear structure over here, which is hypo-intense on T1 weighted image and hyper-intense on the time of flight, and which indicate this could be a vessel. And from its direction, we think that should be a PCOM and artery over here. And on the lower level of the midbrain, you can see the lipoma is not seen over this level. And you still see two linear structure over here, which is iso-intense on T1 weighted image and also iso-intense on the time of flight, which indicate it should be a nerve tissue. And we presume this two linear structure is the oculomotor nerve. On this cartoon, we can see that the oculomotor nerve will exit from the midbrain between the PCA and the superior cerebellar artery. And we know that PCOM artery will connecting with the PCA over here. And so the PCOM artery should be superior to the oculomotor nerve over here. And the lesion is about at the level above or at the level of the PCOM artery over here. So we think that the lesion may not be comprising the oculomotor nerve in this case. So we decide to observe this patient. And the patient came back 1 month later at October 17, and she reported that the right pupil returned to normal size in early October. However, 3 days before she visited us, she felt itchy on the right eye and used flucloxone and armitol eye drops. She found her right pupil dilated about 3 minutes after the eye drops. Armitol eye drop is composed of two components. One is the anatazolin, which is an antihistamine, and the other one will be the tetrahydrozoline, which is an alpha-2 agonist used as a sympathomimetic decongestant, and has been reported to be associated with pupil dilatation. After substituting the anti-allergic drugs, she did not have any further attack of mydriasis afterwards for a 2-year follow-up. The interpeduncular lipoma has been followed by MRI for over 2 years, which has remained the same, very stable condition. So in conclusion, even pharmacologists, mydriasis may respond to 1% pillow cupping partially, and the pillow cupping test, either diluted or not, should be interpreted cautiously. And the neuroimaging study provides a high spatial resolution and help for the differential diagnosis in this condition. Thank you for your attention.